It's quite different being in this seat. I'm actually going to be presenting today, unlike previous times where I just facilitate. So for us for today, we do have our HITH Grand Round, which is really thanks so much for everyone for coming. The topic today is how does your hospital in the home unit compare across Australia? So something which we've been working on for quite a while now. It'll be really good showing some of our journey as well as the current information we do have to share. It's going to be myself presenting as well as Dr. Jenny Hutchison. And for those who don't know me, my name is Dr. Iftah Amith, and I am a hospital in the home consultant in Victoria, as well as I sit on the board for the HITH Society of Australasia. I would like to begin by acknowledging traditional owners of the lands in which we meet online today. We're each joining from different places. For me, that's the land of the Wurundjeri people of the Kulin Nation. I pay my respect to the elders, past and present, and extend the respect to any First Nation people with us today. We would like to also talk about some housekeeping, if this is okay with everyone. We have our HITH Society conference coming up. So all of us which are a bit over the cold, the winter, we're going to have something to look up for in the Sunshine Coast. So if you haven't already and want to register and come and attend and see us face to face, you can use the QR code either on the bottom of the screen or the top of my screen, which will always be there when I'm presenting. We also need to acknowledge the fact that there's no way we could have done this without the support of the HITH Society of Australasia. So if you're not already a member, please do become a member by scanning this QR code, and it will give you a discount to come into the conference anyway. So if you come to the conference, it's definitely worth it. Become a member, and will be fantastic having you part of the group. So let's do this. So we have, how does your hospital in the home unit compare across Australia? Something that seems to be a question everyone asks whenever you have a group of HITH specialists or HITH clinicians or HITH managers coming together. The first question they're going to start asking is like, oh, can you tell us how does your hospital in the home unit runs, or what is your staffing like? Because all of us want to know this information. So I'd like to actually say thank you to all of these incredible people who have made this possible, as this kind of journey and project would not have been able to do it just us. So I'm actually going to name each and every person, as well as there's many more other than those individuals. So we have Rue, we have Evie, we have Jenny who's with us, we've got Michael, we've got Ben, Rebecca, James, the HITH Society board members. We've got Phil, June, David, Archana, Alcar, David Turner as well, Christina, Samantha, Penelope, and as I said, many more. So really, what has the road so far looked like? The key milestones is what I thought will be great to share. So it all started on 27th of July, 2023. So you can imagine how long it actually took us to reach what we've reached now. And it all just started by sending an email to Michael Montalto and James Pollard, asking them for some advice and ideas about why we're not benchmarking. That led down the path which reached to Phil George, and he put me in touch with Ben Rogers, who's a big integral part of this survey as well. So in 23rd of August is when 2023, again, remember 2023, it's a while back, we've actually started drafting the first part of the survey. We had Evie present in a conference 2 years ago. We managed to get the ethics approval. We then had final touches on the survey, which I can tell you, the survey we initially thought of doing and what we ended up doing does not look at the same at all. In the 1st of October 2024, we actually started distribution. On the 14th of November 2024, we presented again at the conference. This time I presented and we started collecting data. And then on the 31st of December 2024, the survey closed. So this is what we did so far. But let's take us to the beginning, because really all of this, you need more than just the survey. We need to actually start with, where are these hospital in the home units? And remember, we're only focusing on Australia at the moment. So to try and find out where are these hospital and the home units, it's first to find out where are the hospitals. So luckily for us in Australia, we do have a resource, the Australian Hospital Peer Group, that actually has listed all of the publicly funded hospitals. So from these peer groups, as you can see, they actually compare like with like, in which different hospitals that have similar characteristics can be grouped together. To make it a bit easier for ourselves, we decide to not look at some of the specialized hospitals because then we deemed it as low yield of being able to provide a hospital in the home service. So this is what we ended up with. So we end up with a map with all these hospitals, but now we need to figure out where are the actual hospital in the home units. So we know the hospitals are, but we don't know the hospital in the home. So this was, again, a very big task and a journey to actually build a comprehensive HITH directory of where they are currently in Australia. We use the HITH Society internal records, which if you go to their website now, if you're a member, you can actually log on and see it. But that was not a complete list. So we had to actually reach out to clinical networks, to the health round table team to provide their data of where they know services are. We looked at publicly available government reports and online databases, as well as local intelligence of asking those around, and really manually reviewing the Commonwealth declared hospitals. So in that document we had, and each hospital going to that hospital and checking if they've got a hospital in the home or not. And this is what we ended up with. So as you can see, it's a smaller number, but definitely significant number of units across Australia. And this is just a nice way to try and bring together in a table how it looks like. So what is actual availability across Australia of having a public hospital, a hospital in the home in a public hospital peer group. So as you can see, these are the peer groups we decided to choose from. To simplify it again, I do apologize. The next one is how we actually got there, the engagement for the completion of the survey. So to complete the survey, we've actually done the conference engagement. We sent out emails to different hospital in the home units. We did do network engagement with the health roundtable, as well as we did some phone follow-ups. We even got the project endorsed by IMSAN's research network, which was quite a tough task to achieve. So then we can get other communities and societies to reach out and be able to advocate for this research on our behalf. But really, the top secret weapon that we had to achieve this task was Ru. So Dr. Ru Niue, who is now a consultant, both endocrinologist as well as gen med physician, has actually been an integral part of calling the units. And I'm sure that a lot of you who are on the call right now who might have received a phone call from Ru. So I thought it'd be nice to put a face to the name as she actually called the units together responses. Now, with the data, there's a disclaimer. This is preliminary data collected from the HITH benchmark survey. The data provided here offers an early insider response for the participating unit. However, it is important to note that this data is not yet undergone full validation and cleaning. So, how did we actually do with collecting data? We had 262 records, which we managed to receive through our red caps. From those, Jenny had the task of actually reviewing each one and removed 137, which were empty, as well as 26, which the completion rate was less than 50%. One was out of Australia, so that was one of our keen friends from across the ditch, which was quite keen to participate, which is fantastic to see, but unfortunately it was out of the scope of this project. And as well as we had 4 duplicates records. So we end up with 94 records, from which we had 45 in public service, 4 private hospitals, and 5 private providers. So if we go back to the HITH availability across public hospitals peer groups, the same table we saw beforehand, as what I was trying to say beforehand was that because there are quite a large number of services that, even though they're quite large in numbers of the actual hospitals, they didn't really have many HITH services. So we decided to actually group it as other, and just display it this way, in which we have a principal referral, which is one major center normally in a state. We have the public acute group A, which is large hospital. As we go, B is lower, C is even lower, and D is the lowest, which is now within the other. So you can actually see that almost in the bigger hospitals, we have more hospital in the home units in Australia. And as the size of the hospital becomes smaller, there's less chance of them having a hospital in the home unit. And overall, from all the hospitals that we have, so around 25%, so a quarter of hospitals in Australia have a hospital in the home unit, which is fantastic. So here, what we have is a dilemma, which we have Michael Montalto on the train rails, because he's the one who brought it up. So we know the numerator, which is how many actually completed the survey. But what is the denominator? So how should we actually review the data and know how many people actually answered? And therefore, if we got a good representation within our survey data. So this took quite a long time to try and think, what is it we're trying to achieve? So really what we came up with at the end was 3 different levels, in which they're all going within each other. So we've got organization, which is the higher up level. We've got the service, which is you can have multiple services within an organization. And then you can have a unit and have multiple units within this service. And that's why it was quite difficult, because the answers that we can get from these surveys that we send out, it could be for an organization, it could be for a service, or it could be for a unit, or it could be for a small hospital, which is within only a small organization, which there's only one unit, which is also the service, which is also only one within the organization. So to try and bring all this together again, we're going back to the actual data that we have from the government. So from the Australian Institute of Health and Welfare, we actually have the public hospital and beds publications. And the publication which we've used for this is the hospital resources. And if you want to go to it, this is just a link down there. The reason why we use this data is because it had something which was quite interesting, which was the local health network. So every single hospital that we had actually had a matching local health network that it was part of. So this is your local health network decided to be the organization. In regards to does it have a HITH, it was decided that if even one of the hospitals within the local health network as a hospital in the home, that counts as it does have a hospital in the home unit. So as you can see, 60% of local health networks in Australia have the ability to provide hospital in the home care. Now, looking at the actual data, bring it all together of the actual survey. So how many actually completed the survey? So for the survey representation, as we said, if even one single survey representation was related to a local health network, we counted that as yes, it was a representative sample within it. So it's quite nice to actually showcase how well we've done it per group that we've looked at in regards to the peer grouping. With looking specifically just at the local health network, we managed to get 60 out of the 77 local health networks to send a representative sample. So that is something we're quite proud of from those which had a HITH. Oh, I do apologize. I think I made a bit of a mistake. So in regards to local health network, it's the actual number of those which have a HITH. It is 47% of all services so all local health networks, 47 of those, we actually have a representation of them. Doesn't matter if they have a hospital in the home or not. And 78% of those which have a HITH we have representation. And 60% of local health networks in Australia have a hospital in the home. Just to flag and be aware, that currently in Australia, if we're looking at the number of local health networks, it says 128. The reason why our numbers don't match is because some local health networks were actually excluded because they're too specialized from when we talked about the peer grouping. And in Victoria, there's actually 76 out of those 128. So that is quite a large representation in Victoria. So Jenny, I'm going to hand over to you to talk about the rest of the data.
Hi, I hope everyone can hear me okay. Yeah. Yeah, so I'm going to try and talk about the data that we've got from these surveys. And first of all, as you can imagine, there is a huge amount of that. So lots of numbers, lots of tables. So we've tried our absolute best to kind of put it into some fun infographics to make it a little bit more tangible, easier to understand. So all of that should be on the slide. And if there's any questions, then obviously popping that in the chat. So we'll go through it. And also as a disclaimer, as Iftah said before, the data isn't clean yet. And so there are some outliers and there are some discrepancies. So it's just to kind of get that initial benchmarking to get an idea of what's going on. So we'll go through it together. So what we've got, we've already gone through this. So as we've got our surveys from the 85 public services. Yeah, and then we'll move, yeah, and local health representation. So 78%. Moving on. So we'll start getting into the responses in the surveys and how they were distributed. So this is a representation, a demographic representation of where the HITH services were. So significant amount in the state of Victoria. And then we sent out our surveys to the states and to the HITHs across the states. And the next slide shows us our survey response. So pretty good response rate from the surveys that were directed towards HITH services. So almost 100% in multiple states there. And understandably, there's not a huge amount of HITH services in Tassie. And moving on. So another kind of representation, instead of state-wise, is where our HITH services are actually based. And unsurprisingly, a good amount of them are based in their metropolitan area and wanting to get patients shifted back into their homes from those busy and centralized hospitals. And yeah, less as we go down. So very few in our remote communities, given that we need so many resources to support our HITH services. And then next, yeah. So this is another way. So obviously there's multiple ways to kind of set our HITH services apart. And this is another one basing on who they're linked to in their organization. And we can see here majority are linked to that acute hospital, but we do have standalone HITH services as well, which was quite an interesting finding, as well as community nursing services and medical clinics having their own HITH services. And this is probably a representation maybe of some outliers. So this is their bed number, but this is in relation to the organization that the HITH is attached to. So obviously each organization might have multiple hospitals, showing us that some of them have 700 to 1,000 beds, but the majority sitting around that 250 to 750. So significantly sized organizations, and obviously needing HITH support to manage those bed numbers. Yep. And another way that we've realized that people can put their HITH services into categories is this self-reporting. So majority are understandably acute care medical, but you can see that we've got lots of iterations of kind of our aged care management. So we've got our rehab, we've got our GEM, we've got our acute gerries, and just showing that how many HITH services are leaning towards that aging population, and as that grows and grows, how important these are.
Perfect, Jenny. And what I'll take over just for the next couple of slides. So as Jenny mentioned, this is self-reported model of care. And it is something that I now just took models of care, put it in ChatGPT and asked it, hey, ChatGPT, can you provide me an abstract picture of models of care in HITH? And provide me with this beautiful picture, again, abstract. And the reason why that is the case is, at the end of the day, this is just, I can call whatever I want at the moment. Nothing is stopping me from calling my model of care whichever terminology which I want. So we decide to actually try and figure out how maybe it should be categorized. So it's always show me the money. It's always coming down to money. So what we can do is actually use ICPA, which is Independent Health and Aged Care Pricing Authority. So what we can look at what is actually the current care types exist within Australia. So we've got these four. We've got admitted acute care, emergency care, subacute and non-acute care, and non-admitted care. Now, within subacute and non-acute care, we do have all of these categories, which look familiar, don't they? They look familiar because they are similar to what we had beforehand with the models of care. So this is an infographic that I came up with about a year and a bit ago, in which it was trying to figure out in my head, how can I find what is the in-hospital care and what is the actual at-home care equivalent and how we should actually call it. For example, intensive care, emergency care, and so on. Now, we've moved past that because this was an ugly infographics and we're trying to make it a bit easier for everyone to digest. So on the left, we have the different admission types in which, according to the actual categories currently funded in Australia, are they all existing in brick and mortar? Yes, they do. But we're not here for brick and mortar, are we? We are, what is the at-home equivalent of it? And this is our suggested way terminology that we should probably call it. So for admitted acute, it's acute adult at home or acute pediatric at home. For emergency, it's emergency at home, rehabilitation at home, and so on. Within the at-home equivalent, which is the larger title, we then going to have different types of model of care. And that is going to be the same as how for admitted acute, you have admitted acute and cardiology is with it. Here we just have a model of care of acute medical, which could be general medicine, acute pediatrics, acute surgical, acute medical geriatrics, and so on, or etological. So it just helps us try and bring it all together of how it should all look like. I will point out something quite interesting is the non-admitted care, which we do see quite a lot of hospital and home services provide that care. So really the way we should view it is, I am an acute medical at home model of care, but I also provide infusions at home because it's not admitted care. And finally, how do we put everything together is with the response rate. So as you can see, you can actually have nice representation. So it's just taking that previous graph and then putting it in this kind of table just to try and put it all together and make sense of it. Jenny, back to you.
So we'll go through some more of the data. So we've got a decent amount of that now. So as Iftah was saying there, non-admitted care, so looking at the admission data, non-admitted care is someone coming in for that infusion and going home again. And then we've got our same day and our multi-day admissions, which can be lumped into separations. So once a patient has completed same day and multi-day as an episode, you can call that as a separation. And then next slide. So we can have a look at in August 2024, so that's obviously the month we've looked at for the whole of the surveys. So in that whole month for the HITH services we were looking at, for same day admissions, on average, they're having 23, and non-admitted care 99, so 99 infusions a month. And then we can see potentially an outlier, mainly you need to go through the data, some HITH services having 1,693 non-admitted care in a month, which is incredible if so. And then moving on to the next slide. And another way that we've been grouping the HITH services is neonates, pediatrics, and adults. So again, showing that the majority of our HITH services are adult-based, but we do have a significant amount of pediatric services, which is fantastic, keeping kids out of hospitals almost more important than adults. And on to the next one. So this shows our multi-day admission. So patients that are under HITH for more than one night and for their episode of care, and showing in the month of August, some HITH services are having 360 multi-day admissions, some having 8, and also having a decent amount of pediatric admissions. So 471 multi-day admissions in some HITH services. And this is an average daily. So on a day, the of patients in a HITH service. So on the average day, potentially some outliers at the top there, but looking averagely around kind of 30 to 20 patients a day. And so yeah, decent amount on the books. Now, moving through this, so one of the questions of the survey was, on an average day, what is the number of face-to-face interactions either nurse, medical, allied health will have with the patient on a day? So average about 36. Now, next question is, how much of that is then brokered out to either a community nurse or a district nursing service? So some are showing that 100% of those are being brokered out, but some are 35%. So just showing kind of the huge amount of demand for nursing services within the HITH service and needing more of that. And then question 25 is looking at how much of those face-to-face interactions were happening in a patient's preferred residence, which is obviously the main point of HITH, is us managing homes. And some services are able to do that 100% of the time and average 83% of the time, which is fantastic, still a great amount. Yeah. And looking at face-to-face nursing care. So there's obviously over 100% there, as you can see, because we're seeing them at multiple different settings. So nursing care, majority of it happening in the patient's home, but also happening in the clinic, as well as infusion centers, emergency departments, things like that. And then the next slide shows the other options. So we're also seeing, obviously, in the pediatric HITH, seeing them at schools and daycares, as well as just being amenable to the patients and our younger patients working, allowing them to continue to work and seeing them at their workplaces. And then the next slide shows us our medical face-to-face. So different majority to nursing staff is we're majority seeing patients in the HITH clinic, which is debatable, seeing as we are a hospital in the home service and we should probably be seeing them at home more. But 50% of patients being seen at home isn't terrible. The next slide is also showing that we're seeing patients also in specialist consulting rooms and also at school or at work. And this is another representation, another infographic showing where face-to-face medical HITH interactions are happening. And again, the main thing coming up is in the HITH clinic. And the next one. So this is showing the availability. So amazingly, from the survey, we can see that some HITH services have an amazing range of MDT, including psychologists and lots of dietitians, social work involved. And it's just showing how available they are to the patients, obviously medical and surgical, medical and nursing 100% of the time. Then the next slide is showing that where can you see those members of the MDT? So psychologists 50% of the time are going to the patient's place of residence, which is impressive, and then podiatry as well as speech pathology. But obviously you see that big drop with surgery. So you can see that hospitals 75% of the time, but understandably 5% of the time in your own home. And also quite a significant drop with medical, like half able to kind of come out. The next slide shows how much can we actually see in the HITH clinic. So surgery comes back up to 97%, understandably, and we get a lot more of the MDT on offer if we do see patients in a HITH clinic. And then lastly is virtual. So another option just kind of also does come with its same issues with an aging population, that how successful those virtual reviews can happen with so many variables in that. But it definitely opens patients up to more of the MDT if they are able to engage with virtual reviews. And this is a distribution looking at roles of nursing and medical staff is the next slide. So nursing staff, seeing how that distribution is, and such a majority with the new admission staff, given that the new admissions take up such a huge amount of workload and need to be so thoroughly reviewed by the admission nurses. And then the next slide showing the distribution for the medical team across the HITH services. So a lot of junior medical staff on the ground, going to houses and going to the aged care facilities as well as in the clinics, and also a role for interns, but yeah, definitely heavily medical senior staff to oversee that out of hours as well. And then and as we all know, the administrative staff and the management is so important in HITH services. I think the continuity between that inpatient and outpatient community care, and especially with notes and IT paper services, how important that is for continuity from in-hospital to outpatient. And then this is showing our patient to staff member ratios for nursing specifically. So it's showing for a patient to nurse. So the average is 3 to 1 patient, which is a decent amount. And then the highest was 33 nurses to a patient, which is impressive. Next one.
Yep. The other way around.
Oh, is it? Oh, sorry, I was looking at the colors. Highest 33.
So it's 33 nursing staff.
Oh, okay. Cool.
So 33 patients per nursing staff.
Yeah, great. And then the next one is probably the medical. Yeah, so showing that again with our ratios there, which you can see. Okay.
So really important to note. So a lot of people want to know what is the ratio in which you should be on. So how many patients is when you need to get an extra junior doctors. So these ratios are specifically for EFT. So EFT we done by the actual full-time position. So at the moment from junior doctors, what we can see from the survey is that on average, 23.5 patients per 1 EFT of junior doctor, or the actual median is more close to, it's lower, 14.5. And then there's the crazy ratios of 250 patients per junior doctor.
Yeah, and same here with the senior doctor. So sorry if just made these slides in the past 24 hours. As you can see, I've not seen these infographics. So as you can see, we have 36 patients to 1 senior medical staff member. Yeah, so again, I'm not quite sure the ratio for when you'd need a new one, but yeah. Next slide. And this is showing the number of visits to a residence in 24 hours and how many that we can do. So some services are able to provide 4 visits a day, which is very impressive, but on the whole, 2 visits if they're requiring multiple infusions a day and requiring medical review as well as a nursing review. And this is our availability. So interestingly, there's kind of differences across the HITH services in how available medical and nursing staff are in hours, out of hours, weekends, weekdays. So this is showing for medical availability, face-to-face scheduled non-emergency care in the weekday, unsurprisingly, and hopefully medical staff are available 95% of the time. But there's a quite decent drop at the weekend to 68% of the time, and some of that might be in relation to the smaller hours, less staffing, but yeah, shows kind of that decent change between weekday and weekend. And then this is showing the availability of nursing care, 24-hour nursing care, also across the virtual setting, face-to-face setting, urgent face-to-face setting, and scheduled face-to-face. So if we take, it's the same for nursing actually across weekdays and weekends. So for urgent virtual review, that's more readily available, 37%. And for urgent face-to-face would be 7%. And then scheduled face-to-face, no, I've done that wrong there. What have I done, Iftah?
No, you're all good. So it's just is 24 hours available. And really, it's very rare for a service to be able to provide nursing care 24 hours for non-emergency.
Yeah.
And then we have the doctors.
So yeah. So, and as you can see, emergency 24-hour care, non-emergency out of hours is scheduled face-to-face, non-emergency for 24 hours, not available for medical staff. Can do urgent face-to-face reviews and urgent virtual reviews are available more readily 24 hours a day, which is quite surprising that 24 hours a day a doctor is on call to do a virtual review overnight for patients, 24 hours a day. So this is also just another thing that we were looking at with the survey is duration times and clocking in and clocking off and the difference people have across the HITH services. So this is looking at the nursing care duration windows. So this is looking at weekends and weekdays for non-emergency care face-to-face. So shortest windows of 5 hours, longest windows of 15 hours, and an average window of 11 hours. And that's for scheduled face-to-face non-emergency care. And the next slide is showing medical scheduled face-to-face non-emergency care. Again, relatively similar over the weekends and the weekdays. Shortest was 3 hours, and our average is 8 hours, understandably, but some HITH services having that out of hours cover for 14 hours for the non-emergency face-to-face reviews. And this is also showing, quite surprisingly, one of the other options at the end of the survey is what technologies HITH services are using in patients' residence, which I think is quite impressive to be able to offer some of these technologies in a patient's home, especially mobile x-rays. And looking at, there was also some, on the next slide, it's actually showing some newer technologies that some of the HITH services are using, like vein finders. I think, speaking from personal experience, sometimes patients having to come into hospital specifically for their blood, I think a huge amount of time and effort and money. And I think any services that are available to kind of help that aspect of HITH. Also, some services, HITH services have taken up HITH apps, so engaging in that technology aspect. Obviously, with our aging population, sometimes there's issues with that. But I think with that availability of virtual reviews, engaging in a HITH app probably is extremely useful going forwards with HITH.
So this brings us to future analysis considerations. So now, as we showed you, we have some of the earlier data. So we really need to do data validation analysis, make sure that things were not put in error and actually make sense of it. We were thinking of drilling into the pediatric specific data, compare rural versus metro services, correlate between service size and staffing role, as we saw, because as you can see, it varies quite widely. Break down between models of care, which we talked about, as well as role-specific data. So what is it that we've actually learned so far? Undertaking a national survey is extremely difficult. So as you saw, this was 2 years in the making, and it's not even finished yet. If you're ever doing a survey yourself of this caliber, direct calls were the most effective. So that's where we really got the majority of our responses. Survey fatigue is real. So all of those which are on the line who complete a survey or are actually part of the survey fatigue and didn't complete it, you'll realize this was a very large survey with a lot of data and a lot of questions, which we want to get, but really it did fatigue people. And the terminology interpretation varies across services as well. So if done again, what is it that we could do different? So building more administrative support, I think will be a great idea. Use a phased or modular survey design. As we said, it's quite a large study, so maybe send out chunks of it at a time. Focus on key questions over granular data, which again, we have so much of it. Refine and test survey language more thoroughly, as we do know people might interpret the questions differently, as well as use interviews for detailed information. So instead of doing interviews for everyone, just for specific groups to get your right answers. So reflection to the wider HITH community after this data, because that's the whole point of collecting this data. It's not just to get publication, it's actually reflect on it, which will be great to hear from you all as well. So national benchmarking is valuable and achievable. So we did show it can be done. Investing in national contact list and directory would have made our life a lot easier. Comparing like to like, the same as how we've got peer grouping for the hospitals, which are the brick and mortar. Why don't we have a comparable like and like system for a hospital and a home unit? So then if you do want to compare yourself to another unit, you need to you'll be able to actually say, look, I'm unit level B, and I want to compare myself to another unit level B. You should not be comparing this apples with oranges, just apples with apples. We need clear terminology and data standards. So as we said, the actual model of care, we need to have actual definitions and say what each definition actually means. Let's keep sharing what currently works between each other and consider actual national infrastructure for data collection for comparability. The same as what they're doing for hospitals, we should do for brick and mortar, we should do it for our own units as well. And again, a reminder about the upcoming conference, which I'll present further data as well, analysis. There'll be other fantastic talks as well. It'll be incredible to see you there. And we'll finish with questions. So if you have any questions, please put them in the chat and we can then go over them. So let me see what we have already. We have lots of AI people adding it, so that's nice. So from Nicholas, we have, how was HITH defined for this project and how does it align with the society definition? So Nicholas, that is a fantastic question. And specifically, around the time of when the survey was initially coming up with was around the time when the definition was initially presented. And it was decided to let services self-define themselves as HITH. The reason for that is because we want to know what is the current landscape ongoing in Australia. We did not want people to have that constriction, and then we want to compare afterwards with the data. How does it compare to the definition? Is the recording being shared? Yes, it is. So the recording, all of our recordings for the Hospital and the Home side for Australasia sessions for the grand rounds are uploaded to our Hospital and the Home HITH Society YouTube, and it should be in the invite email as well. Is data from exclude small services retained for specialist HITH services study? So James, it's a great question. So we didn't exclude smaller services. So we just combine them into other. In regards to specialized HITH services study, the issue is if once we become too specialized, it becomes too granular, as well as you can then know which services are which, and that will impact the ethics. Now the question is, can you consider including residential in-reach services in a non-admitted box, as there is IHA Kappa Tier 2 classification and lots of activity delivered in the person's home that just happen to live in residential aged care? So Karen, that is a fantastic question in regards to in-reach. And really, in-reach at the moment, we're all going to go back to models of care and definitions. So as some of you might know, in-reach is that's what's called for residential aged care assessments and care within these to patients who live in these locations. It's called in-reach in some states call it outreach. Again, we don't have an agreement on the terminology, and that's really where it highlights the point that we need to define it and explain what it is. As for some services, modes of care, in-reach actually means hospital in the home, but within residential aged care. For other places, it just means it is an ED diversion service, and other ones, it's subacute. So really, we need to have this definition. We have, are those high ratios a data outlier? Yes, it is. So, well, sorry, we don't know. That is the right answer. We don't know if there are data outliers as of yet. We still need to analyze it and have more information. Hopefully that answers the ratio. We have a question from Michelle of, does this include on-call phone reviews or only virtual? Michelle, if you can write in the comments just in regards to what you were asking, and then I can clarify. The survey fatigue is real. Yes. Do you mean the respondents get exhausted with a lot of questions? So Dan, yes, both to actual just not completing the survey or not starting it. And then we also have the ones which, if you send multiple surveys, which we all know that people love surveys for research, then if you send too many, people will not complete it. We have, how did we recruit patients? So this was not patient-based. This was for hospital and home units, and there were lots of different ways we recruiting them. As we spoke about, we can listen to the recording. We then have, did we collect outcome data? No. So unfortunately, we did not collect outcome data. Initially, the initial project which we wanted to do was actually to have two steps, in which the first step was completing the survey we just completed, which is benchmarking. And the second step was actually collecting patient data information for 2 weeks blocks, and then comparing between and correlating what is actually happening in regards to the service, how they run, and what is about the patient which they provide the care for. Unfortunately, we realized that as a group, this was too much to undertake as first round, and probably we should just do the benchmarking first. And after we learned from it, then we can do another survey in the future. We have in regards to existing accreditation, doesn't already link data collection for HITH, who should be collecting, owning this data. So we do have some organizations, that's the health round table, that does collect this data and does have the ability to report, but they don't have full data sets, unfortunately. We have from Julie Adam, Iftah, I've been in contact with a private hospital CEO forum convened by the federal government. One of the 4 focused areas are hospital substitution treatment. Excellent. Glad to hear that, Julie. That's wonderful news. And we do have lots of discussions in regards to, is this the right data? Are we collecting the right data? Which is a very good question. Are we providing like with like? And I think that's a really good point to highlight. Exactly what we said. You can have 2 hospitals that in the government data collection are viewed as the same peer. So let's say they're both level A hospitals. It doesn't mean that both the hospital and the home services that are within that hospital are actually the same type of hospital and the home services. And that's why we should have our own separate way of comparing our services to each other. All right, so Michelle did clarify for us. So does this include on-call phone review or only virtual? This in regards to the overnight nursing and medical unplanned reviews. So we did not clarify specifically if the on-call was just a phone call or virtual, and that's on us with the way we asked the question. And what is the greatest surprise from this? Anything really good or really bad? That's a really fantastic point to ask and a really great question. The biggest surprise for me with this was the fact that in Australia, at the end of the day, we are kind of doing the same thing across the board, just a bit differently. So it's nice to see that probably if we have strong enough guidelines, we can all be similar, but also the fact that we do need to be a bit different to accommodate for the special needs of your own region. Having agreed relevant KPIs for HITH patients would be a great thing for the HITH Society to advise on. Yes, that will be amazing in the future. There are specific HITH KPIs from Queensland. If anyone wants Queensland Health, if anyone wants to review it, you just Google it, Queensland Health HITH KPIs. I've got my suggestion as well of how KPIs should look like in the HITH space. And we did ask about KPIs in our survey. And this is data which, if that's something which people are interested in, I can present at the HITH conference of what people have answered across in Australia. Oh, we have another one. Given the way HITH and community care is heading, requiring more efficiency using virtual visits and increasingly digital enabled, it would be great to gather more information on what percentage of work is virtual and how technology is improving efficiency or not, and what is working well, what is not working well, and how acceptable it is to patients. This was from Christy. That's a fantastic point, and would definitely, if you want to reach out, we can look into doing this in the future. And I was asked to type my email, which I'm very happy to do so. for anyone if they want to contact me. And seems like that is the questions. We do have a question in regards to any recording will be available. Yes, also all recording will be available on the HITH Society. So the HITH Society YouTube channel, which I might actually put it just there. And I will, so if anyone wants to go to the YouTube channel right now, they can, and view our other amazing presentations. And again, all of this project, which I've been working on for the past 12 plus months, would not be possible without all of you guys' help. Michael, let me see if I can unmute you. Ask away, Michael. You should be able to unmute. No? Okay. Excellent. Thank you so much, everyone. Really, really appreciate you attending as well as contributing for those who contribute the information. Of course, this is not the end of it. This is just the start of it. So please reach out if you have any questions, if you want to discuss anything specific. Thank you, Jenny, for contributing as well and being part of this presentation. And come find me at the conference as well if you want to chat or have a coffee or anything like that. And have a beautiful rest of your day. Thanks so much.